Hello, sir.
Yeah, hello.
Please, I think you can start now.
Okay. All right.
Hello, Grandmama.
Yeah, hello.
Good morning.
Good morning.
I hope you're doing well.
Yeah, I'm fine.
Your voice is not good, crowd. You just got up.
No.
And now, Oko, baby. All right, then. Now we can let's start, please.
All right. Okay, so today's topic will be rational use of medicines, and as part of it, we will look at some of the strategies that can be used to control irrational use of medicines. Specifically, we will discuss issues on the essential medicines list and the drug and the therapeutic committee. These are part of the strategies that can be used to control irrational use of medicines. So, when do we say that we have achieved rational use of medicines? To be able to say that you have achieved rational use of medicines or you've used medicines rationally, it means that you should be able to achieve all the following 4 factors. If you miss out on even one of them, it means that you've not achieved rational use of medicines. What goes into it? So we can convince ourselves that yes, we are using drugs rationally only when the medication is appropriate to the clinical needs of the person who is using the drug. Please mute. There is somebody's mic is activated. Please mute. All right. So the medication should be appropriate to the clinical needs of the person using it. For example, if you have malaria, then the drug that you are going to take should be able to cure the malaria. So it should be an anti-malaria, not an anti-cancer agent. It should be appropriate to your clinical needs. So if you give the wrong medication, or if the drug is not indicated, then it becomes irrational use of medicines. But again, the dose should meet that individual's requirement. The person who is going to take the medication, after you've ensured that the medication meets or is appropriate for that person's needs, you should also ensure that the dose is also appropriate when it comes to that person's individual requirement. So you have different category of patients: elderly population, children, those with organ failures, especially organs for metabolism and elimination. If you pick an adult patient with renal or liver impairment, and there is a medicine that is metabolized or eliminated by these organs, then it is obvious that you may not be able to give such a patient the normal adult dose. Though the person is an adult, you may be compelled to give maybe half the normal adult dose. In this case, if you still give the normal adult dose and this person can't handle it, then the drug may accumulate and cause toxicity. It means that the dose does not meet that person's requirement, though the person is an adult. If you are looking at children of course, based on their weight or body surface area, you do the calculation and give the dose that meets their own requirement. It's not about generalization. It should be about individualization. Then, for what period? How long is the person going to use this medication? Is it 3 days? Is it 5 days? Is it 2 months? Is it 6 months? The duration should also be adequate. You are taking an antibiotic or an anti-malaria, for example, the ACTs, and it's supposed to be 3 days. You don't take it for 2 days or 5 days. The duration of therapy should also be appropriate or adequate. Then again, if the person doesn't have enough money or cannot buy the medicine, then it will not even be available for you to consider its appropriateness and what have you and whatever. And therefore, the cost is also very, very important. Once you can't afford, the drug will not be available. Therefore, as part of the principles of rational use of medicines, the cost should also be favorable to the person using it and to the community at large. You should be able to secure all the four before you can confidently say that you've achieved rational use of medicines. The appropriate drug meeting the clinical needs of the patient, the dose that meets that person's individual requirements, adequate duration of therapy, and at the lowest cost favorable to the person and the community. Do not miss even one, because if you do, then you've not used that type of medication rationally. Class captain, is there any issue so far?
No views.
Hello? Class captain, can we continue?
Yes, please, we can continue.
Your voice is like very, very faint today. Are you using some headset or something?
These are things. Let me solve that issue.
Okay, so now, it is obvious that if you use medications that goes against any of these four principles, then we say that you are not using the drug rationally, or you are having irrational on or non-rational use of medicines. And that is a very huge problem. Very, very huge problem. Why are we saying that? If you consider the global perspective, you realize that when it comes to those who prescribe, those who dispense, and those who use the medication, the consumers themselves, 50% of those who prescribe, those who dispense, and those who take them, they do not follow the principles of rational use of medicines. And therefore, they always prescribe, dispense, or use drugs irrationally. That is 50% irrationally. That's a huge problem. Aside this, an alarming thing is that almost 1/3 of the world's population do also lack access to essential medicines. This is one of the problems that leads to irrational use of medicines. Because if you lack access to essential medicines, anything that you chance upon, you can use it anyhow. If a quack person comes in and bring you anything at all, since you are sick and you are not having access to the appropriate medication, you try and use it. You want to survive. So lack of access to essential medicines, which are the medicines that we need to be able to meet our basic healthcare needs in terms of drugs. If you are not having them, then it creates a whole lot of problem. Once you lack access to essential medicines, you are not able to treat your condition. It gets severe, you get complications. What happens? You end up being hospitalized. So you get increased morbidity. And if you are not lucky, there will be increased mortality. If some of these things happens, either hospitalization or mortality, it means that you are going to waste resources. If you were able to get healed in the house for this ailment of common occurrence that did not even need hospitalization, you wouldn't go to the hospital and pay excessive amount of cash to get healed. At times you pay and the patient will not still survive. Once you are not getting access to appropriate medications from the recommended source, issues like antimicrobial resistance is likely, because anybody at all comes in, gives you medications like antibiotics. You may not even be having bacterial infections, then you use it. A quack person comes in, any small infection, he wants to give you injection, because he knows that locally we understand that once you are giving injection, then it means that is the proper treatment. It means that, yes, you've been treated well. So they give you those things, quack persons, you waste resources, you create antibiotic resistance. You put a lot of pressure on the healthcare system, because once everybody doesn't get access to medications, they get complications. Everybody is rushed to the hospital. You put a lot of pressure on the hospital. Here is the case. We also have limited staff and even limited resources within the hospital setting. Then it creates a lot of problems. You go there because you are putting too much pressure, because you are getting a lot of referrals to the hospital. They also run out of stock. The staff, they are stressed. They can't give top-notch services. People waste a lot of time at the hospitals because they are coming in too much. They are not getting their medications over there. What happens? They lose confidence in the healthcare setting. And these are some of the problems that can result from irrational drug use, all the way starting from low or no access to adequate or essential medicines, creating a lot of complications, morbidities, hospitalization, putting pressure on the healthcare system, you wasting resources, paying more than what you are supposed to pay. And that is the huge problem that can occur when anybody is engaged in irrational drug use. Now, we need to know the types of irrational drug use. That is, if you actually want to solve the problem of irrational drug use, you need to know the types. So you assess. But before the assessment, you should know examples of irrational drug use so that the assessment can be done, and then you try and develop some means to solve it. So let's look at quickly some examples of irrational drug use. One of them is polypharmacy. Technically, polypharmacy is when you use 5 or more drugs per prescription. So one patient is coming for his or her medications, and normally you have more than 5 drugs per prescription. This is very common when it comes to the aged, the elderly population. But as you age, you get more complications, you get hypertension, for example, diabetes, renal impairment, each of them contributing about 2 or more drugs per the patient prescription, and obviously you are going to get polypharmacy. If the drugs in there are indicated, then that will not be a problem. But polypharmacy becomes a problem when the drug is not indicated and you add them. Like treating malaria, the person doesn't have any anemia. It's not every malaria that leads to anemia, yet you want to add hematinic to it. That drug is not indicated. If it adds up and increases the number of medications per prescription, then you are performing what? Polypharmacy. Remember the 4 cardinal points of rational drug use. The drug should meet the patient's clinical needs. If the person doesn't need a hematinic and you give, it causes the act of what? Irrational drug use. So polypharmacy, inappropriate one, will be deemed as irrational drug use. Inappropriate use of antimicrobials, especially when you don't use it in adequate doses, or when you don't even have any bacterial infection. This normally happens in the community setting. You have some women all the time at the end of their menses. They feel like taking antibiotics. They feel like they have some infection there, which they really don't have. And therefore, they use this antibiotic. The worst thing is that they come and they want to buy just 10 capsules of amoxicillin, 10 tablets of metronidazole, 200 milligrams. And that is what they always do. You explain to them and they are surprised because they've been doing this since. Number one, they don't have any bacterial infection. Number two, they are taking inadequate doses, inadequate quantities. What are they likely going to cause? Antibiotic resistance. Then overuse of injections when oral formulations would be more appropriate. Yes, you have a condition that oral and injections are both appropriate, but considering the convenience and safety.
Hello, Dr.
When it
Baba.
comes to oral, yeah, hello.
Please, I have a question.
All right.
Please, concerning the polypharmacy, based on the explanation on the slide, you said many medicines per person. But you also explained that when the medicine is
What's on the slide is not an explanation.
Oh, okay.
What is on the
explanation
slide is just a point.
Oh, okay. Okay, then
What I said is the explanation.
Okay, all right. Thank you. So,
all right.
In the case of heart failure, where so many medications are given and they are all indicated, it doesn't qualify to be polypharmacy.
No, it's polypharmacy, but it's not irrational.
Okay. All right. Thank you.
All right. Okay. Any other question? Last captain. And somebody. All right. Okay. So overuse of injections, when in that case oral medication even will be more appropriate, or even when the two are appropriate, but you realize that when it comes to safety issues and convenience, oral medications would be more appropriate. Typical example is when somebody has gonorrhea, an STI, where both oral medications like cefixime, ciprofloxacin, and injectables like ceftriaxone are all indicated, but the person decides to use the ceftriaxone injection, where cefixime oral or ciprofloxacin oral is also indicated. Based on the risk involved in injections, the risk alone, it can even create abscesses, cause a lot of problems. And you decide to use the ceftriaxone over the oral cefixime, then it becomes a case of irrational drug use. When clinician fails to prescribe in accordance with their clinical guidelines, it's likely that you can make mistakes. If you follow clinical guidelines, it is less likely to make mistakes than you doing your own thing, because the clinical guidelines are based on evidence. The drugs that are recommended are normally selected from the essential medicines list, which are also based on evidence on safety, efficacy, and even cost effectiveness. So why are you doing your own thing? You follow the clinical guidelines, you are less likely to make mistakes. The patient benefits. Then inappropriate self-medication, especially when you use prescription-only medicines. These are all common examples of irrational drug use that you can cite. All right. Now that we know, how do you assess the problem of irrational drug use so that you develop solutions to solve the problem of irrational drug use? So to be able to address the issue of irrational drug use, it starts all the way from those who prescribe, those who dispense, and the end users. Remember, we said 50% of prescribers, 50% dispensers, 50% consumers. We all are at fault when it comes to irrational drug use. 50% prescriptions doesn't meet the requirement of rational use of medicines. During dispensing, almost 50% of the cases irrational. Then consumers, anybody at all can be a patient. So we are all involved. We don't take our medicines properly. 50% cases we are wrong. So how do you assess the problem? You should be able to know the type of irrational use that is occurring. This is the only way to be able to develop strategies to target that problem. If you don't know the type, how do we even develop a strategy to address it? So you should know the type of irrational drug use. Then you should also know the magnitude, the amount of the irrational drug use, so that if you apply your intervention, you will know where you started from. And if your intervention is truly working, you can also measure the impact, how your intervention is working to address that type of irrational drug use. And you should also understand people. And therefore, you should know the reason behind the use of drugs irrationally. You should know. Because everybody, either it's a good reason or bad reason, it's still a reason. So why are they using these medications irrationally? You should be able to know, so that you give them appropriate, effective, and feasible strategies to solve the issue. Always note that in most cases, people will have rational reasons for using medicines irrationally. What they are doing is irrational, but they have rational reason. A typical example is when you lack access to medicines, you are sick. You don't have any chance of getting any medicine. Then, lucky enough, somebody comes in as a peddler, an itinerant medicine supplier, comes to your village and sells drugs to you. You will do it. You will take those medicines and hope that you get well. It's an act of irrational drug use, but the person has a rational reason for taking the drug, because the person doesn't have access to any medication. And therefore, once he gets the chance to take one, he will use it. However, it's an act of irrational drug use. Lack of access to medications, it's always. Hello? Class captain.
Hello, sir.
Okay. So now that we know the principles of rational drug use, some examples of irrational drug use, how to assess the problem so that we can develop strategies to solve the problem. Let's look at some of the strategies that have been put in place to try and curb the issue of irrational drug use. So we have what we call 12 core interventions that can be used to promote rational use of medicines. Each one of them is very, very important. So let's look at some of them. The first one is a mandated multidisciplinary national body to coordinate medicine use policies. You need policies so that it will shape everybody in line when it comes to rational drug use. One of them is the National Drug Policy. In there, you have principles of good dispensing practice, principles of good prescribing practice. At least, when you have such a policy, the prescribers are keeping in line what they are supposed to do during prescribing and what they are not supposed to do. The dispensers, what we are supposed to do, what we are not supposed to do. And of course, we are talking about drug use, and it shouldn't be based on any single professional. When it comes to drug use, everybody should come in. So it should be interprofessional collaborative approach. And therefore, a multidisciplinary approach is the key thing to develop appropriate policies that will keep everybody in line. It will tell us how to prescribe, how to dispense, how to even procure, store. All these things are very, very important. We also need clinical guidelines. We cited that when doctors, they prescribe and they don't follow clinical guidelines, it is possible that they can cause irrational drug use from the point of prescribing. So we need clinical guidelines. We need to develop clinical guidelines. Ghana, ours is the STG. Very old, but at least we have something. Nowadays, the various subspecialties are trying to develop their own guidelines based on specific conditions. So you now have the diabetes guidelines locally prepared. We have even asthma guidelines, our TB guidelines, and what have you. These are very, very important because as you practice in accordance with these guidelines, you are not likely going to make mistakes. Guidelines always goes with recommended medications, and these medications are what you normally have in the essential medicines list. And therefore, the development of the essential medicines list is very, very important. At least those drugs will meet the basic or the priority healthcare needs of that country. And therefore, these drugs are selected based on evidence concerning safety, efficacy, cost effectiveness. So when you choose these drugs, it means that you are likely going to chop success in terms of efficacy, safety, and cost. Lucky enough, whenever you buy the STG, they add the essential medicines list to it. This has so many advantages, some disadvantages as well. Later on, we will look at the pros and cons of the essential medicines list. So that one too is one of the strategies that can be used to try and control irrational drug use. If not for anything, the cost, efficacy, and safety. All the drugs that you find in there, they have all these attributes. Then the presence of the drugs and therapeutic committees in hospitals and districts. What at all is the drug and therapeutic committee, and what will be their role in promoting the rational use of medicines? So normally this is a committee that is set up, the composition, multidisciplinary approach. You have pharmacists in there, clinicians in there, nurses, and even non-health professionals. Their main target is to control and manage any drug-related issues within the district or the hospitals in terms of procurement of medicines, which medicines are supposed to be procured to the hospital, safety issues when it comes to handling adverse drug reactions, development of the hospital's drug bulletin or the hospital's drug formulary. All these issues are handled by the DTC, including education, educating everybody within the hospital when it comes to drug-related issues. With this, they can help control irrational drug use. Then when it comes to our training in schools, lucky enough, nowadays, the PharmD program is solving that problem, where before you even come out from school, you are exposed to the practical aspects of pharmacy practice. Previously, it was geared towards theoretical issues. Then you have to come out and then you begin to learn. But nowadays, the program is more of a problem-based pharmacotherapy approach. So right now, you are not yet a pharmacist, but I strongly believe that you can practice fully as a pharmacist. This is because they've changed the curriculum and now it is handling this issue. It is now a problem-based pharmacotherapeutic approach, not solely theoretical. Then when you come out from school, you become a professional pharmacist. Science is always dynamic. Health is science. And therefore, if you don't update yourself, you become archaic. Gone are the days when we're using ampicillin for gonorrhea. Nowadays, if you dare prescribe ampicillin for gonorrhea, then you are in trouble. And therefore, CPDs as a real essential requirement by the regulators, especially Pharmacy Council in our case, is also very important, because if the person becomes archaic, he's going to prescribe useless medicines, and that will not be in line with the principles of rational use of medicines. And therefore, continuing in-service trainings, continuous professional development as licensure requirements can also help, especially when you are considering the prescribing and the dispensing aspects, those things that contribute to irrational drug use. So that is what is going on now. Now, before you be allowed to renew your license as a pharmacist, you need to show evidence of continuous professional development. With that, at least, the regulator knows that you've updated yourself and at least you've added something new to what you already know. And therefore, it's likely going to help you improve upon your expertise that can contribute to rational use of medicines. Then supervision, audit, and feedback. This is something that normally we lack in our local setting. As for supervision, yes, you may have a senior colleague supervising you when you are working. But when it comes to clinical audit, it's a problem. When even any bad thing happens, we try to cover up. We don't expose the thing. You go for clinical meetings, mortality meetings, and people are trying to cover up. They don't want to. Elsewhere, in the UK, US, because of the insurance issue, clinical audit is very, very important. And this is very good because if you know that you'll be audited, you do things the right way. So if you are supposed to give, say, metronidazole for some anaerobic infection, then you prescribe clindamycin. The two can do the job. Metronidazole is relatively cheaper. You go and give clindamycin and you want the insurance company to come and pay that higher amount. They will come in and do the clinical audit. You have to justify why metronidazole could have done the trick with a relatively lower cost, but you decided to prescribe clindamycin for that anaerobic infection, and they will not pay. If they don't pay, you may have to pay. So clinical audit is very, very important. We don't do it here, but it is something that can also be used to help care. Remember, cost is there. So if Flagyl is cheaper, can do the job, why do you create unnecessary cost by prescribing clindamycin? Then independent information on medicines. Yes. This normally will come from the drug information unit. You don't rely on information from medical reps. They are handling their own brands, so they are likely going to be biased. So we need a lot of drug information units. These people, if you contact them, they are giving you unbiased information because they are not promoting any particular brand of a certain molecule. Confanochi, we have our own drug information unit. When you go there, if you have any issue concerning any drug, not brands in particular, they will give you unbiased information, independent, because they are not being sponsored by anybody. If you follow medical reps, they are always biased towards their brand, and they will try to convince you. For all you know, that brand is not even the best. Then you'll be prescribing, you get negative outcomes. Then one of the most important things, public education about medicines. Public medications about medicines, very, very important. Even with the professionals, you can't say that you know everything about medicines, let alone lay people. And therefore, continuous public educations when it comes to the use of medicines is very important because they are the end users. This can also be used to control irrational drug use. Then prescribers and dispensers, avoidance of perverse financial incentives. Prescribers and dispensers. These medical reps will come in, they make a deal with the prescriber. Normally, they even give a prescription pad, notebook. On each page of the prescription, a certain drug has already been stamped with the dose on it already. Let's say a hematinic. So the brand will be there. They will write even the drug with the brand. I don't want to mention any drug. So let's say drug E, already prescribed on it. And then the doctor will negotiate with them. So as many of the sheets that goes out, they calculate and multiply by the charge. So if the agreement was like per each prescription, the doctor will earn 5 sheets. As many as he pushes, they will multiply by 5 Ghana, and then he will go and collect it from them. In this case, what is going to happen? The moment you pick any prescription, the drug is on it already. So whether you need it or not, whether you need the hematinic or not, because it has been stamped on it already, it becomes automatic. And that drug may not be indicated for the patient. So when you prescribe for cash, financial incentives, or you, the dispenser, you try to push a certain brand of medication because you are going to be paid, that will not contribute to rational use of medicines, but rather irrational use of medicines. Then the regulators, Pharmacy Council, FDA, HIFRA, and the rest, we need appropriate and enforced regulations. You already know what they do: monitoring, inspections, disciplinary actions, and what have you, certain standards and everything for drugs, code of ethics, and what have you. Once they are able to work well, you follow everything, you are keeping in line. What is going to happen? It is going to contribute to rational use of medicines. Then the last but not the least, the government. You need to push in a lot of commitment. Cash. You hire more staff. Few staff will be stressed. More mistakes will happen. And once you prescribe with mistakes, you dispense with mistakes. That will not contribute to rational use of medicines. The drugs are supposed to be available. So the government should make the necessary commitment to make the drugs available. If the drugs are not available, you lack access to them. If you chance upon anything at all, you don't have any choice than to use it. If you don't hire more staff, some job that about 10 people are supposed to do, you go there and you have just 2 people doing it. They will be stressed and a lot of problems will occur. So these are some of the interventions that can be put in place to try and solve irrational use of medicines. Should in case you are asked to discuss the problem of irrational drug use or inappropriate drug use, or discuss issues about rational use of medicines, obviously your approach should be first giving the definition of rational use of medicines and stating that anything that goes against those 4 principles, it makes or it creates a case of irrational or inappropriate drug use. You try and cite examples, those polypharmacy issues and the use of antibiotics when the patient doesn't even have bacterial infections, using injectables when oral medications are more appropriate, and blah, blah, blah. You cite some examples like that. Then you try to assess the situation by identifying the type, the magnitude, and the reason behind the irrational use of medicines. And then you come out with some of the interventions, the 12 core interventions, the ones that you can really explain and link it to achieving or how it will help or contribute to the achievement of rational use of medicines. Then you conclude. That should be the approach. Introduce your discussion by defining what rational use of medicine is, making a statement that anything that goes against that becomes irrational. Cite examples. Assess the situation by telling them the type, the magnitude, and the reasons, and why you need to do this assessment. Then you tell them possible interventions, strategies. Some of the 12, because you can remember all the 12, you cite them and you explain each of them briefly as to how they can contribute to the promotion of rational drug use, and then you conclude. Class Captain, any questions?
Yes, please.
All right.
Hello.
Yeah, hello.
Yeah, please. You mentioned that there's a national body that coordinates the rational use of medicine. So I wanted to know which
There
national
should
body.
be. There should be, not that there is. It's not everything that you are seeing there that we have. This is the ideal thing. For example, as I said, we are supposed to have clinical audits, which in Ghana is not a common thing. We don't do. But ideally, we are supposed to have a national body that should be in charge of developing policies when it comes to drug. We have some bodies for the development of policies like the Ghana National Drug Policy and several other policies when it comes to conditions. But setting up this to look as in to take control properly in case of irrational use of medicines, we normally we don't have yet, but we should have it. Please, are you okay?
Yes, please. Thank you.
All right. Any other question? Class Captain.
No, please, sir.
All right. So quickly, we talked about regulatory bodies that they are supposed to give us appropriate or adequate standards and enforce them. So what are some of the regulatory measures that can support rational use of medicine? So briefly, Class Captain, why do we need to register medicines, and how does this promote rational use of medicines? Registration of medicines, how does it contribute to rational use of medicines? FDA does that. Do you think that is even necessary? And how does it relate to rational use of medicines? Class Captain.
Hello, sir.
Do you think it's necessary to register drugs? And if so, how will it promote rational use of medicines?
Okay, so I think it's important to register drugs, because in looking at rational use of medicines, you want to be able to give the right drug to the right patient. And then for you to know, or registration of medicines from FDA will suggest that if the medication is actually registered by FDA, that means it's actually a medication that would have an efficacy. So if you want to promote rational use of medicine, where you are looking at providing the right medication for the right patient, I think registration of medicines by FDA can help in achieving such a target.
Very good. Thank you. So as you said, that should be the case. All drugs should be registered, because once a drug is registered by the appropriate regulator, you are assured, at least when it comes to quality, safety, and efficacy. These are very, very important when it comes to rational drug use. Then another regulatory strategy is limiting prescriptions of medicines by level of prescriber. Very, very, very important, because based on your expertise, there are certain medications that you may not be able to handle properly. For example, if you are not an oncologist and you are allowed to prescribe anti-cancer medications, it is obvious that you may cause harm to the patient. You don't have that level of knowledge, that level of expertise. If you are not an anesthesiologist, maybe you are an ONG as in expert, then you decide to take upon yourself issues of anesthesia. So you are doubling as an anesthesiologist, and an ONG expert, you are likely going to kill somebody. And for that matter, that one we have. We limit drugs in Ghana according to level of care. If you are in the community setting, for example, a CHIP compound or the pharmacy setting, these fall under the community level. You should know the type of medications that you can handle and you are allowed to give to patients. There are certain medications that if you dare try and anything happens, especially when in the pharmacy you begin to give injections, even penicillin, and somebody gets allergic reactions, you could be in trouble. And therefore, limiting prescription of medicines according to level of care is also very, very important. You only allow only those who have the expertise to handle certain type of medicines to do so. Those who don't have, you just give them what they can handle. And this can help improve or support rational medicines use. Then setting educational standards for health professionals and developing and enforcing codes of standards. Yes. So in your practice, Pharmacy Council, they have a rule. When it comes to the type of programs or courses that you read, your educational institutions, they always collaborate with Pharmacy Council. If not, and you, the educational institution, you do your own thing, at the end of the day, Pharmacy Council will tell you that your students are not up to that level that they need, and therefore they cannot register them for them to become pharmacists. That is how come if you come from another country and you want to register in Ghana, you have to submit all your documents, including the various courses that you've read. Pharmacy Council will assess, and if it doesn't meet their requirements, they may ask you to go and take some 1 or 2 courses as a top-up before they will allow you to even take part in their professional exams. And therefore, to avoid this, if you are a local institution, educational institution, you collaborate with Pharmacy Council so that you meet their requirements. Very, very important. Once you come out to code of conduct, very, very important. Pharmacy, we have our own PSDH code of ethics. You follow, you are safe. If you try to do your own thing, you are likely going to be in trouble. These are all examples. Pharmacy Council have their professional conduct that you have to follow. If you go against that, you'll be accused of committing a case of professional misconduct and you'll be in trouble. You realize that all the cases that are deemed as professional misconduct in one way or the other can be linked to irrational drug use. If you are supposed to be at the pharmacy as the superintendent pharmacist and you decide not to stay there, once you are not there, almost all the things that goes on there could result in irrational drug use. Giving medications to patients without any information can happen. It can result in irrational drug use. Giving the wrong information, giving the wrong drug, giving unwholesome medications to patients in your absence. All of these things can happen. And therefore, as part of the standards of Pharmacy Council, the pharmacist is supposed to be on the premises. All these are regulatory issues that can help promote rational use of medicines. Licensing of health professionals, obvious. Before you be licensed, it means that the regulators, they deem you as what? An expert in the field of, for example, in our case, pharmacy practice. And therefore, they trust you. The country knows that, yes, you have the requisite knowledge and skills to provide the nation with a top-notch pharmaceutical care. You are up there. The medicines outlet themselves, the premises are also supposed to be licensed. We've discussed this with Dr. Ishak. The requirement when it comes to you applying for the license for pharmacy premises, there are some requirements that you must meet. Even the size of the premises, the types of rooms that are supposed to be there, the customer area, the dispensary, the store, the office, the whatever, the washroom, everything. All these things are necessary. If not for anything, when it comes to drug safety, the way you even store your drugs, it may be exposed to factors that can increase drug deterioration. All these are very, very important for the regulators to make sure that Once the premises meet the standards, it will contribute to safety, efficacy, and quality of medicines, which in turn will promote rational drug use. Then monitoring and inspection by the regulators. Once you know that they will come around, you do the right thing. You'll be there. Once you are there, rational use of medicines is assured. So these are all examples of regulatory strategies that can be used to support rational use of medicines. Now, specifically, let's look at these two strategies. Hello. Class captain, your mic is on.
No, please.
So let's quickly. It's not you.
No,
Okay.
please.
Let's quickly look at.
I think it is someone.
Someone please mute. So let's quickly look at the essential medicines list and the DTC as one of or two out of the 10, 12 core interventions that can be used to curb irrational drug use. But before the essential medicines list, quickly, let's look through these pharmacokinetic terms. Because the essential medicines list, it will get to a point where you have drugs that are therapeutically equivalent, that you need to select one into the list. And we need to understand the term therapeutic equivalence. And because of that, you never know how the exam may go. Anything at all can happen. So you will not only look at that term, but other related pharmacokinetic terms we need to understand. Then we come back to the essential medicines list proper. When do we say that two drugs are equivalent? So drug equivalence. So this is when one drug is similar to another with respect to bioavailability or therapeutic efficacy or any other established standards that you want to use to compare the two drugs. If they are similar, then you can say that those two drugs are equivalent. So you want to set any standard. You want to know whether you want to check the bioavailability of two medications. You set your own standard that if a drug falls within a range of 95 to 100% in terms of the amount that will go into the bloodstream from the point of administration. It doesn't matter whether it is IV, IM, rectal, or oral. Once at the end of the day, you get 95 to 100% of the drug in the bloodstream, then you can say that those drugs that fall within in there are equivalent in terms of bioavailability. So you administer drug A, you administer drug B. At the end of the day, you have one of them 95%, the other 97%. Since both are within the range, the set standards, you can confidently say that in terms of bioavailability, drug A and B, they are what? Equivalent when it comes to bioavailability. This is just an example. You can also use therapeutic response. So efficacy. So drug A, drug B, you give it, and both are able to give you similar results. The patient gets healed. And you can say that in terms of therapeutic response, those two drugs are equivalent. Class captain, are we okay?
Yes, please.
Okay, then we have pharmaceutical alternative and pharmaceutical equivalent. What is the difference between the two? So when do we say that two drugs are pharmaceutical alternatives? So drug products that contain the same active ingredient. So you have two drug products. They have the same active ingredient. So diclofenac in drug A, diclofenac in drug B. But they have different salt forms. So diclofenac potassium, diclofenac sodium, or even esters. Or they differ in dosage forms or strength. So when you have two drugs, number one, their active ingredient is the same, but they differ in terms of salt or ester form or dosage form or strength. then you can say that they are pharmaceutical alternatives. So by using diclofenac, for example, in terms of salt form, you can have diclofenac sodium, diclofenac potassium. These two are pharmaceutical alternatives. You can also have diclofenac that is injectable, diclofenac that is oral, the tablet, or diclofenac that is supposed to be used rectally, a suppository. Since they all have the same active ingredient, diclo, but the dosage form is different, you can say that they are pharmaceutical alternatives. Or you have diclofenac oral, that is 75 milligram, diclofenac oral, that is 50 milligram, diclofenac oral, that is 100 milligram, or the suppository that is 100 milligram. Since the strengths are also different, but they contain the same active ingredient, they can be deemed as pharmaceutical alternatives. In that case, if you need this strength, but you don't have, but the other strength is there, you could use the other strength to achieve the same target. So if you want to use 50 milligram TID, diclofenac, to achieve the maximum daily dose of 150, as per the BNF, you don't have, but you have the 75 milligram per tablet. It makes those two pharmaceutical alternatives. And therefore, if you are hard pressed, you can use the 75 milligram and make it BD so that you again achieve the same 150 milligram maximum dose per day. So that is pharmaceutical alternatives. Then you have pharmaceutical equivalent. When do we say that two drugs are what? Pharmaceutically equivalent. So drug product, again, that contains the same active ingredient. And this time, they are identical in strength, concentration, dosage forms when it comes to route of administration. This is when you say that those two drugs, pharmaceutically, they are equivalent. It starts from the two drug products containing the same active ingredient. By this time, they have the same strength, concentration, dosage forms. So this normally applies to brands. So you have diclofenac tablet, tablet A, tablet B, one from company C, one from company Z. But they have the same active ingredient. They are all tablets for oral administration. And they have the same strength. These two agents, if they prescribe specifically the brand A, and you don't have the brand A, you can decide to use the brand B, normally after consultation with the prescriber. And these two are considered pharmaceutical equivalent because they contain the same active principle. They are the same dosage forms. They have the same dosage forms. They are all tablets, oral tablets. They have the same strength, 50 milligram, 50 milligram, 100 milligram, 100 milligram. Then it means those two products are pharmaceutically equivalent. What else? Bioequivalent. When do we say that two drugs are bioequivalent? So what is bioequivalent? Two medicinal products, again, containing the same active principles, are considered bioequivalent if they are pharmaceutically equivalent. So remember pharmaceutical equivalent. So pharmaceutical equivalent, same drug, same strength, same dosage form. Or they are pharmaceutical alternatives. Alternatives means two brands containing same active ingredients, but different dosage forms, different esters, different salts, and what have you. So it doesn't matter. The two drugs could be pharmaceutically equivalent or pharmaceutical alternatives. But the good thing is that their bioavailability, that is the rate and the extent of absorption from the site of administration, they are similar and they fall within the acceptable predefined limits. As I cited, if your predefined limit is bioavailability of 95 to 100%, once the two drugs, it doesn't matter, they could be pharmaceutical equivalent agents or they could be what? Pharmaceutical alternatives. Once in terms of bioavailability, they fall within your predefined limits, you can say that they are what? Bioequivalent. What is the purpose of bioequivalent? It is very important because it can give us a fair idea when it comes to safety and efficacy issues concerning the two drugs. So bioequivalent, certain concentration, certain percentage within a certain time limit in the bloodstream. This can detect efficacy and safety issues. If you fall within the therapeutic window, efficacy. You fall below the window, no efficacy. You fall above the window, toxicity. So bioequivalent can be used to predict both efficacy and safety. Then the last one, therapeutic equivalent. When do we say that two drugs are therapeutically equivalent? So this describes drug products, again, containing the same active principles. And they have the same therapeutic effect, if not the same, similar. Not only that, they should also have the same or similar tendency or potential to cause adverse effects. So two drugs containing same active ingredients, they have possibly similar efficacy and also similar potential to cause adverse drug reactions. When two drugs display this, then we can say that those two drugs are therapeutically equivalent. In selecting medicines into the essential medicines list, you could have two or more drugs with this property being therapeutically equivalent. We have limited resources and we can't select all medicines into the list. And when it comes to this level, how do you choose drugs? How do you choose between the two drugs that are therapeutically equivalent? We will discuss that very soon. Class captain, any questions?
No, please.
Okay, so this is an example, just trying to demonstrate what we mean by bioequivalent. So they've decided to set the limits 0.8 to 1.25. So once any drug falls within this limit, then another drug, let's say the innovator brand, is normally at the perfect point, one. So if you test another drug against the innovator brand and it falls within this range, this is your predefined set limit, then you can say that your generic agent is bioequivalent to the brand. I don't agree with the use of the term original brand, but once you use original brand instead of innovator brand, the opposite of original is fake. So it means that then the generic is fake. So I'm comfortable with using the term innovator brand rather than original brand. If they come and you don't have the original brand, then it means whatever you have is not original. If something is not original, then it is fake. So stay away from using the term original brand. Better use innovator brand. Another example, you are comparing this red drug and the green drug in terms of bioavailability or bioequivalence to the innovator, that is the blue drug. And your predefined limit is 80% to 125%. You are okay with it. Always the innovator is at the perfect point, 100%. So it means that for any drug to be said to be bioequivalent to the innovator, it should fall between 80% to 125%. We can see that the full length of the red drug is within the range. As compared to the green drug, you can see that this arm has gone above the upper limit of 125. And therefore, we can conclude that since the red drug is within the range, it is bioequivalent to the innovator. But since the green one has gone beyond the upper limit, it can be said not to be what? Bioequivalent. You could have it also going below. The same thing will be the conclusion. still not bioequivalent with or to the innovator brand. So what are some of the causes of variation in bioavailability? Some possible contributing factors to variation in variation when it comes to bioavailability. It could be patient factor, it could be drug-related manufacturing issues and what have you. So let's look at it. Route of administration. If you give a drug by IV, 100% versus a drug by the rectal route, obviously you are not going to get 100% absorption. So there will be variations between the one that was given per IV and the one that was given per the rectal route. At times, it could be due to formulation issues. The dosage form, that would dictate the route of administration. The type of excipient that was used, the disintegrating agents, the binding agents. So at times, you could have too much binders. You could have very bad disintegrating agents. These agents help release the drug. That can affect the drug release. And of course, it will contribute to the absorption at the end of the day. So formulation issues can also lead to, and this is normally the problem with generic brands. You compare the innovator to the generic and the bioavailability is way different. You go in there, you realize that it was as a result of issues with the formulations, the type of ingredients that were used, especially the excipient. Then the molecule itself, you know, drugs, we have grade A, grade B, grade C. Some people will go and, because of cost issues, they won't buy the grade A active ingredient. They will go and buy grade B. And there could be differences in the two compounds, the grade A active ingredient and the grade B, in terms of solubility, stability, and even interactions. So if you go and buy grade A that has perfect solubility, if your drug doesn't go into solution in terms of oral preparations, absorption becomes a problem. So somebody is using grade A active ingredient, solubility is on point. You go and buy grade B ingredient to manufacture similar product, solubility has questions. And since your drug is unable to go into solution perfectly as the one who used the grade A, you are likely going to have issues with bioavailability. Then patient factors, either as a result of physiological or pathological factors. You could have some patients with issues when it comes to GI absorption. Intrinsic factor as an example. You don't have it, then your B12 absorption becomes a problem. Some patients do have GI issues. Yeah, hello?
Yeah, please, Mr. Samolama, kindly mute.
Hello?
Samolama, please kindly mute your mic.
Can we continue?
Yes, please.
All right. Okay, so you could have some of the issues that can create a lot of variations when it comes to bioavailability. Even the site of administration. Using insulin injection as an example. You've injected at one particular site, you've caused lipodystrophy. Subsequent administrations can result in reduced absorption and therefore reduce bioavailability. First pass effect, depending on where you are administering the drug. You inject it straight into the bloodstream, you've dodged first pass effect. Some of them, if you take them orally, you are going to have first pass effect in the GIT. Even before it gets to the liver, where you can also have hepatic first pass effect before it gets to the bloodstream. So where you administer the drug can also affect variation. So these are all possible contributing factors when it comes to bioavailability. Enough on the kinetics. This was just something that I felt we should add so that should in case you have any issues on such. So we'll go back to our EML, that is the essential medicines list. So what is this list? This is a list of medicines that meet the priority healthcare needs of a certain population. Obviously, the priority healthcare needs when it comes to you will be different from the priority healthcare needs when it comes to Ghana. Let me use malaria as an example. You go to the UK, malaria obviously will not be part of their priority, their basic healthcare needs, because hardly do they get malaria there. But if you come to Ghana, malaria, if not number one, will be number two. And therefore, the essential medicine list when it comes to Ghana is likely going to be different from the essential medicines list for UK. So we should understand that depending on your priority healthcare needs, you select drugs into that list. Now, these drugs are selected based on evidence when it comes to efficacy, safety, and comparative cost effectiveness. You have two drugs, you need to compare them in terms of cost effectiveness. If I say cost effectiveness, class captain, when it comes to treatment, what do we mean by cost effectiveness? Comparative cost effectiveness. So drug A versus drug B, we are saying that when it comes to comparative cost effectiveness, A is better than B. What do we mean by that?
Okay, so with the cost effectiveness, you are examining the cost and then the in terms of efficacy of the drugs. So you are comparing the cost and then their outcome. So for drug A and drug B, in terms of the cost and then outcomes, if let's say drug A is, let's say, cheaper than drug B, but then in terms of the outcomes, they have equal efficacy, or in terms of outcome, they are equal, we can say it's cost effective.
Okay, so let me come in. So when you are talking about comparative cost effectiveness, drug A versus drug B, you need to start assessing the two drugs, not on the cost based on a dose, but after the end of using those two drugs, what will be the final cost? Considering the outcome, as you said. So, for example, you have uncomplicated malaria. You go and buy Coatem, that brand, 100 cedis. I have same uncomplicated malaria. I go and buy another brand, 12 Ghana cedi. You take your Coatem, you are healed. Yes, malaria is gone. I take the 12 Ghana cedis, it couldn't clear the parasites. Then mine graduated to complicated malaria. So I was rushed to the hospital. I was admitted at the ICU. Over there, you have to pay a lot. So 2,000, 3,000 Ghana cedis. Then I also get healed. I come back. Obviously, the one who started with the higher cost, 100 cedis, versus you who started with the 12 Ghana cedis. In terms of comparativeness, when you are comparing the two, cost effectiveness, the Coatem man has enjoyed that one because of using that drug, versus you that you use a cheaper one. So if you are looking at cost effectiveness, you don't look at the cost per dose, but you look at the cost when you are done doing the whole treatment. At the end of the day, using drug A versus drug B, what was the end results in terms of cost? That is how you consider it. So yes, you are looking for evidence on efficacy, safety, But because you always have to choose, you are talking about choosing drugs to become part of the list. So you are always comparing things, and then the one that will have favorable factors, favorable attributes, you choose them and you add them to the list. So you are always comparing stuff. So you compare them based on evidence on efficacy, of course, safety, and also cost effectiveness. So the ones that will have these attributes, they are efficacious, they are safe. When it comes to cost too, favorable, then you choose them, and especially in our part of the world that cash is a huge issue. That is what we do. If not, the drug could be efficacious, very safe, but it's very expensive. You add it to the list, and quickly, when you get even one pack of the drug, it has consumed all your cash and you can't buy any other. So you need to consider cost. Cost is also very important because it forms part of the definition of rational use of medicines. Remember, we are saying that essential medicines list is one of the strategies that can be used to curb irrational drug use. All these are important when it comes to promoting rational drug use: efficacy, safety, and cost. Now, drugs that are selected, it should be based on at least the following: the results of efficacy and safety evaluations, if possible, obtained from a controlled clinical trial or epidemiological studies, or the drug's performance when it comes to its general use. These are very, very important because it is practical, not theoretical. Now, when you have several drugs to choose from, especially for the same indication, choose only the drug and the dosage form that provides the more convenient benefit-risk ratio to be part of the list. So you have several drugs that can be used for malaria. Several drugs. You can't choose all of them. You have to choose one or maybe two to become part of the list. You need to consider the one among that list and the dosage form. In terms of benefit-risk ratio, that is what? Having better results as compared to the others. So benefit-risk ratio is also very, very important. Now, when it comes to drugs with therapeutic equivalent, as we have discussed already, drugs having the same active ingredients, similar efficacy rates, and also the potential, similar potential to cause adverse drug reactions. That is when we say that those two drugs are therapeutically equivalent. So if you have two or more drugs that are therapeutically equivalent, how do you select one or two or some of them to be part of the list? You need to consider the following. So when it comes to drugs that are therapeutically equivalent, one, you choose the one that has been more thoroughly investigated, the ones that you have more evidence backing it. Here again, in terms of safety, efficacy, and cost issues. The drug with the most favorable pharmacokinetic properties, of course, again, from evidence. And the drug with the lowest cost, very important. Calculated on the basis of the whole course of treatment, not just per dose, as I said. The drug with which health workers are already familiar, yes. If you bring in new drugs, remember that you need to train all the health workers on how to handle the drug. So normally when new drugs are in, you don't just quickly add them to the essential medicines list. If you go and buy them and the health workers don't know how to handle it, for example, it's an injectable powder for injection, and they don't even know how to reconstitute it. They don't even know issues about storage, its shelf life after reconstitution and those things. Then you need to spend cash to train people on that. If you have another one that they already know, and it is also therapeutically equivalent with the new one, why do you have to waste your time? Rather going for the new one Meanwhile, the two are therapeutically equivalent. Choose the one that those who are going to handle the drug, they are already familiar with. Then you don't have any issue of going to spend money to train anybody. They know how to handle the drug. Then choose the drug for which economically convenient manufacturing is available in the country. Yes. But this thing in Ghana, it's an unfortunate issue. Even most of the locally manufactured products that we expect that they are supposed to be cheaper compared to even the imported ones are more expensive. You have a lot of brands locally manufactured that are expensive than most of the UK generics. But all things being equal, it's expected that locally manufactured drugs will be cheaper than foreign ones. And therefore, if you are choosing from 2 drugs or more that are therapeutically equivalent, the one that it is possible for us to manufacture locally is the one that you have to choose. Again, choose the drug which shows better stability at the available storage conditions. So looking at our system, our setting, the drug that can withstand our storage conditions, our weather, the temperature, that is what you have to choose. Now, there are issues with fixed dose combinations. When do you choose a product that comes as a fixed dose combination? You have, let's say, para and diclofenac or lisinopril and amlodipine combined in one tablet. When do you choose a fixed dose combination over choosing the 2 individual drugs and adding them into the list? When do you choose the fixed dose combination over the single agent individually selected into the list? Now, a fixed dose combination should be accepted as part of the list only if there are clinical justifications that the patient will need the 2 drugs. Of course, if there are no justification to use 2 drugs for hypertension and 1 drug is okay, why do you have to prescribe a fixed dose combination or dispense a fixed dose combination? Because the person needs only amlodipine or lisinopril, 5 milligrams, and it can control the BP. So why do you give a product that contains amlodipine and lisinopril at the same time? So those drugs should only be selected if there are justifications that the person needs to use those 2 drugs concomitantly. That means a single drug of which one of them is part only is not able to control the BP. Okay, let's continue. And the combination provides a proven advantage over a single compound administered separately. Here again, taking the 2 as in 1 tablet provides advantage as compared to taking the 2 drugs separately but at the same time. Is there any evidence that supports that? In terms of cash, cost issues, safety, efficacy, and even compliance. Obviously, when you are taking 2 in 1 tablet, you'll be taking fewer tablets. So you have lisinopril and amlodipine in just 1 tablet. So when you swallow 1 tablet, you have swallowed the 2. But if you have them separately, it means that you are going to swallow 2 tablets at a go. Would that contribute to improve compliance? Obviously, that should be the case. But that shouldn't be your only consideration. Won't that contribute to cost? Because by producing the 2 in 1 tablet, won't it be more expensive than going to buy the 2 separately? If it's going to increase the cost, then you shouldn't select a fixed dose combination into the list. If it's going to improve efficacy, select. If it's not going to improve efficacy, you better choose the 2 separately into the list. This is what they are trying to tell you. In addition, for safety issues and the idea to promote rational use of medicines, medicines are confined when it comes to circulation of medicines according to level of care, as we've already discussed. So it means that based on your expertise, you are placed at a certain level of care, and that your level of care will dictate what kind of medicines that you can be allowed to prescribe handle or stock in that facility. This is based on level of care that goes with expertise. This will help minimize irrational drug use. And according to the essential medicines list, level of care has been grouped into this. Please note this. This is very, very important. This goes with the type of medicines that each level of care is allowed to handle. If you check the NHIS list, you will see that every drug has this superscript. So you see diclofenac, then you have maybe A, superscript. You see paracetamol, you have A. It means that they are telling you that paracetamol is a drug that is allowed to be used at the community level. You see oncology medicines is likely going to be SD, superscript, so specialist drug. If you look, I don't know whether you have the chance to look at the NHIS list. They have all these. If you look at the essential medicines list, they also have this superscript there telling you that this drug is a specialist medicine. This drug can be handled at the community level. This drug can be handled at the midwifery level. That is superscript M. So these are the levels. So A is community. Examples of community facilities. Community pharmacy, the retail pharmacy. We are there. CHIP compounds, we are there. So obviously, they will give you certain medications that are not that dangerous. That's the CHIP compound where you only have some training, maybe public health nurse or some nurse can handle the drug with reasonable safety. Midwives dealing with delivery issues, pregnant women and those things, they have their own group of medicines. So obviously, oxytocin and blah, 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 blah. Those drugs are likely to be labeled as level M. Then B1, if you have a health center, but there is no doctor there, then of course, once there is no doctor, then compared to B2, where you have a health center with a doctor, you know the type of medicines that you can handle. Then C, which is district hospital, better than both B1 and B2. Then D becomes the regional and teaching hospital. Then those that are labeled SD are specialist drugs of medicines. Then the PD, which is program drugs. So these program drugs normally are reserved for special conditions. For example, TB, HIV, those things. You reserve those drugs for those programs. For example, TB drugs, rifampicin. You have people stocking rifampicin in the community pharmacy. What for? They are using it for gonorrhea and those things. No, you are likely going to create resistance. When the person that you've introduced rifampicin gets TB or is having TB at that time, why don't you use other alternatives? You have to what? Preserve or reserve those drugs for TB. So those drugs, they are only what? Reserved for those programs. So TB drugs are program drugs. Malaria drugs are program drugs. Drugs that are used for the expanded program when it comes to immunization, all those drugs are program drugs, and they are supposed to be as in deemed as such, not use them for other conditions. So that these are the definitions or interpretations for the various drugs. So specialist drugs, these are drugs that only the specialists in that field may request for them. If you are not part of that specialty, you don't request for them for obvious reasons. And the program drugs are the drugs that are used in the public health programs of MOH. And therefore, they are used within the guidelines of that program. As I cited, TB medications, HIV medications are part of the program drugs. Now, always note that when it comes to the essential medicines list, it is recommended that drugs are labeled or written in there according to the international non-proprietary name. You don't prepare essential medicine list with brand names, no. Likewise, you don't prescribe medications with only brand names. You use international non-proprietary name. And if you want to insist on a certain brand, you put the brand name in brackets. If you are a pharmacist or a dispenser and you are labeling your drug for a target that is a particular patient, you bring the name of the drug at the back of the envelope. Make sure that you have the international non-proprietary name there. If you need to add a brand, you put that one in brackets. Then in the essential medicine list, we have what we call the core list and the complementary list. So the core list are the ones that meet our basic healthcare needs. So the basic ones that in Ghana, malaria drugs, for example, obviously part of the core list. But the complementary list are the ones that, in most cases, we don't need them for basic healthcare. Maybe for specialist healthcare, fine. So if you are doing a core list for, let's say, a CHIP compound or a community whatever, or for M, or let's say B1, B2, you don't need to worry yourself too much about complementary list, because over there you may not even have any specialist there. But when you are doing your list for, let's say, Konfanoche or Kwalebu, since we have specialty care, you should have both the core list, which consists of the ones that meet our basic health care, and the complementary list, which includes specialist range of medicine. Class Captain, are we okay? Any questions?
No, please.
All right. So quickly, this essential medicines list that we've been talking about as part of the strategies to curb irrational drug use. What are the advantages and the disadvantages? So the first advantage is attaining maximum benefit from limited resources. Obviously, Ghana, we don't have a lot of cash. Limited resources when it comes to what? Cash. With this list, you knowing that, yes, there's a list there that any drug that you buy, we need that drug because it meets our basic healthcare needs. And of course, it is likely that the conditions that people present with, they will need that drug. You have cost effectiveness, you have efficacy, you have safety. You just pick the list, and with your limited resources, you know that, yes, okay, I don't have any money, but if I buy from this list, it will be enough. Compared to when you don't have this list and you have to go to the open market without any drug in there, you are just going to buy. Meanwhile, you have small cash. You even be confused. Which one should I buy? Drug A or drug B? But with the essential medicine list, you are guided. So even with the limited resources, you are able to make excellent purchases. And when the drugs come in, it is the conditions that people will bring that your drug is going to target. And when they use it, since those drugs are selected based on evidence of safety, efficacy, and cost effectiveness, it will be on point. So it's very, very essential, very, 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 very critical to even as in those who are living in these third world countries. We don't have a lot of cash. And therefore, it gives that maximum benefit considering our limited resources. So that is the very first advantage. The second one is it assists in the development of standards, guidelines. Remember, we said it is the drugs in this list that are recommended when it comes to the standard treatment guidelines. And therefore, you can use the standard treatment guidelines to is one of the strategies to curb irrational drug use. It has a lot of economic advantages. It helps to lower costs through economies of scale. Yes, priority. You have your wish list. Topmost, second in command, third in command. And of course, you buy what you need the most. You don't just go and buy anything at all. With this list, you'll be guided. You'll be guided. It also has medical advantages. Of course, we are talking about efficacy and safety issues. When it comes to prescribing, you know that the moment you prescribe from using a drug in the essential medicines list, safety is assured, efficacy is assured. Your patient can also buy. So in terms of medical advantages, we are there. Even NGOs, foreign ones and local ones, if they want to donate any medicines to any hospital and they get the essential medicines list and buy drugs that are in there, they won't come and then donate drugs that are useless to that hospital. At times you realize that they will donate certain medication to a certain facility. Hello?
Hello.
Sorry, somebody just called. So if even NGOs want to
hello,
donate
sir.
medicine, yeah, can you hear me now? Hello? Hello?
Hi.
What's happening? So if NGOs, for example, they want to even donate some medicines to you and the essential medicines list is available, they want to go and buy it themselves. They pick this list. They go and buy drugs that are in there. They bring those drugs, they will be useful to that company. Rather than they going to the open market, not knowing what to buy, so they just buy any list of medicines. They present it to you and you can't even smile because you know that these drugs, you don't need them. They are going to sit on the shelves and get expired. How about disadvantages? Anything that has advantages in one way or the other will have some level of disadvantages. One of them is it reduces freedom of choice. Since you are going straightly by the drugs in the list and the one that you buy, you don't have any choice, but you are prescribing from that list. You don't have any choice. And therefore, it will also create monopolies. Only those that are in the list are the ones that you are going to depend on. You don't have the chance to choose any other. It also reduces possibilities for gaining episodic experience. For example, new application of old drugs. So at times, you realize that, for example, chlorpheniramine in those days was used for typhoid. Now you are using the newer agent, the macrolides, the fluoroquinolones, and the cephalosporins, and they are not working. But in the list, since maybe chlorpheniramine capsules has been eliminated because of, let's say, efficacy issues, you go into the list, you don't have it, so your pharmacy team will also not stock it. And therefore, if you want to go back and then try your hands on chlorpheniramine and see whether now the typhoid, they've forgotten the strategy to defend themselves against chlorpheniramine, you don't have chlorpheniramine on the list. So you can't go back and then use it. So that becomes a disadvantage. Then lack of interest for drug innovation. Yes, you want to bring in a new drug, you want to perform some investigations, research work, and bring in new drugs. Remember, there is those issue of familiarities and those things. Once you bring in one drug and it is therapeutically equivalent to existing ones, then obviously they are going to choose the ones that health professionals are familiar with. So that will not even encourage people to go and then do research and then bring new things. So that is another disadvantage when it comes to the essential medicines list. Please note this because these are potential exam questions. Class captain, any queries?
No, please.
All right. So the second strategy. The other ones, you realize that you don't need to go into detail. You know them, like problem-based therapeutic approach, you can explain. Education, when it comes to public, you can explain. All those things. Multidisciplinary team to, as in develop policies, you can explain. Avoiding financial, as in perverse financial incentives. Acquiring generalized information, not biased ones, you can explain. But technically, they can ask questions on these two, the essential medicines list and the DTC. That is why we are going more into detail. So that is enough when it comes to essential medicines list. So quickly, let's look at the drug and the therapeutic committee. Others prefer to call it with other names, the pharmacy and the therapeutic committee, the medicine and the therapeutic committee. So what is this committee? This is a committee that evaluates the clinical use of medicines. They develop policies for managing medicine use and administration, and they manage the formulary system. So formulary like British National Formulary, a list of medicines that are going to be used by a certain hospital or the whole district, all the hospitals within that district, they develop those formularies, the Drug and Therapeutic Committee. And anything that is related to drug use, positive, negatives, education when it comes to drug use, they are in charge of it. So when we say formulary, we are talking about a document that describes medicines that are approved for use in a hospital, a clinic, or a healthcare system. Yes. Others also will term the DTC even a formulary committee, but that is just part of the things they do. So a committee dedicated to selecting, developing, and maintaining a list of approved medicines for a hospital or clinic. So it means that after development, they always review and improve upon it. They maintain and add on based on the evidence that will be presented to them. This is one of the jobs of the DTC. Formulary system, a system of periodically evaluating and selecting medicines for the formulary, maintaining the formulary, and providing information in a suitable manual or a list. Drug bulletin as an example. This is part of the job of the DTC. Why do we need DTC? Is it even necessary for us to have DTC as part of the hospital as in setting? In Komfo we have DTC. We have the Drug and the Therapeutic Committee. Since all that they do is about medicines use, and we have huge problems when it comes to medicines use in the hospital. Almost 30 to 40% of every hospital's budget goes into drugs. And therefore, if you don't handle drugs very well, it means that you are likely going to lose almost 30 to 40% of the hospital funds, which may collapse the hospital. And if their work doesn't go well, you are likely going to create irrational use of medicines. If they don't list the appropriate medications that the hospital needs, the essential medicines list is there. That is general for the whole Ghana. But depending on where you are, your locality, you may have some conditions as your topmost priority as compared to another region or another locality in Ghana. And therefore, the whole list is there, but you also need to create your own formulary, depending on your locality, where you are. That is why it should be district-based and even hospital-based. So CAT, we have our own DTC. You go to other districts, they may have their own DTC. Because we spend a lot on drugs, we can't afford to joke with drug issues. Very, very important. What is the structure of DTC? Normally, it is a multi-expert approach. You have doctors, nurses, pharmacists, and all things being equal, you have a doctor, a very respectable one being the head, with the head of pharmacy being the co-chair or the executive secretary. But in Komfo, you rather have the director of pharmacy as the chair, and the others are floor mates. So in Komfo DTC, the DOP is the chair. We will not allow anybody, since it is drug issue, we pushed so that we have the DOP as the chair and the others as members. Okay, now what are the basic functions of DTC? One is advising medical, administrative, pharmacy department when it comes to drug-related issues. So advise which drug to buy, which drug not to buy, which drug to accept into our list. Everything is done by the DTC. They develop medicine policies and procedures within the hospital. They evaluate and select medicines for the hospital formulary and provide for its periodic review so that they can add on. They assess medicines use to identify potential problems. So they do it. They don't wait for the problems to occur before they address it. They have to be proactive, so they also do it. They promote and conduct effective interventions to improve medicine use, including educating the whole staff, nurses, doctors, pharmacists, what have you, everything, they do it. When adverse drug reactions occur, they manage it. Medication errors, they manage it. Everything about DTC is drug-related issues. And considering this type of work that they do, it is obvious that when they do it well, it will contribute to rational use of Medicines. Any queries, class captain? If not, we quickly look at one or two questions, then we close. Class captain.
Hello, Dr. Nico. Firstly, all right.
Yeah, hello.
Hello.
Yeah, hello.
Yes, I wanted to ask, the DTC, is it a mandatory something which emanates from a policy, or the hospitals can choose to set up?
In fact, it's a mandatory thing. If you look at the Ghana National Drug Policy, every district, and depending on the level of the hospitals, they are supposed to have DTC. But unfortunately, most hospitals and districts don't have. Looking at the things that they do, there are so many things that we are supposed to do, we are supposed to, as in have, but in Ghana, we don't do. That's why we are still a developing country. Do this, you go there and it's not there. They should have this, you go there and it's not there. So the accreditation guys will come in and they will say, okay. Ideally, they are supposed not to give the accreditation. These are all part of accreditation requirements. But they come and, okay, what can we do? Let's give it. Because you can't run a hospital without this committee performing these functions. Because these functions are critical. But most people don't have. Where I work, we have a DTC. That is Ghana. Most developing countries, you go to some countries, they don't even have practicing pharmacists within the hospital. Just here, Côte d'Ivoire, you go there, you'll be surprised. Most hospitals will not even have. Most places, they don't even know that pharmacists are supposed to work as clinical pharmacists in the hospital. All that pharmacists do is to either teach in the universities or work within the community pharmacies. There are a lot of things that goes on in developing countries. Hopefully, we will get there. Please, are you okay?
Oh, yes, please.
All right. Any other question? Class captain, can you see question 5? Is it clear?
Yes, please.
Okay. Right. So let's try question 5 and 6, then we close. Mr. Smith, a pharmacist at Smith & Smith Pharmacy Limited in Ghana, began purchasing pharmaceuticals from the open market and using them to fill prescriptions at his pharmacy. In time, he began adding external substances to a particular drug product to increase its bulk and sell to patients in order to rake in supernormal profits. This practice continued for a long time until the law caught up with him. Your task. Question A. How is this practice termed? B. Mention 5 other examples that could account for debasing a medicinal product. And C. How could the above practice be prevented or minimized by the authorities? As always, please, when you get to the theory, please, after reading the question, don't just read the very first one and start providing your answers. Make sure that you read all through to the last one, at least so that you know how to provide your answers, to avoid repetitions, because you don't have much time. You can't afford to waste time. If you read only question 1 and you provide your answer, you go to question 2, then you realize that some of the things that you wrote under question 1, you've wasted your time. You should have come to question 2 and you don't have time. So please read through all the questions, all the things that is expected of you before you start answering the question. If possible, you read through it once first, then you go back to the main case, read the case again. Since you've read the questions, your second reading will help you identify where most of the answers are. For theory cases, whether clinical or laws, in most cases, you realize that about 50-60% of the answers are in the case, that you just go in there and then reproduce it. You don't need to create anything. That is how come I always say, theory questions are far cheaper than MCQs. Most of the answers are in the cases. So make sure you read through to the end. You come back and read the main case again. The second reading, you should be underlying the areas where you can pick as part of your answers. So class captain, do you get the whole picture of this case?
Yes, please.
All right. So how would you answer question A?
Okay, so looking at the case, this is a case of adulteration because the pharmacist in question is adding extraneous substances to a particular drug so that he can increase the bulk and then make supernormal profits. So this is more of a case of adultery.
Perfect. So the term for this act or this action or this practice is simply an act of adulteration. Very simple. You've seen that they've allocated 5 marks there. It means they want you to pass. They want you to pass. For stating only adulteration, you are getting 5 marks. It means that if you also missed out. Yeah, hello?
Okay, maybe you want to finish, then I'll ask the question.
Okay. It also means that if you get it wrong, then you are in big trouble. You've lost 5 good marks. All right. Please ask your question.
So I was asking, just stating the term is the five marks. I was thinking maybe you'd have to define it and this.
No, they said, what is the practice termed? You get it? See, in this exam, they don't even have time to mark. And you guys are many nowadays. So you should be precise and concise. Just give them what they've asked you before you try and anoint any examiner. In most cases, they will ask candidate to provide 2 examples. The candidate knows about 20 examples. So he or she decides to give what, 5 or 10. You get 0. It means you don't understand the question. You've been asked to give 2 examples and you are giving 5 examples. You are wrong. They'll give you 0. When they say 2 examples, give them 2 examples. When they say 1, give them 1. Even when they ask you for 2 and you're able to give 1, at least you get 1 out of the 2. But giving more than what they've asked you is 0. So please take note of those things. Don't go there and be giving extra answers. Just look at the exact thing that they need from you and give it to them. So this one, you were asked to what? Give a 10. How is this practice termed? The worst you can do is to just make it a statement like an act of adulteration. Yes. Somebody can just write adulteration, just 1 word, and it's enough. But you write it an act of adulteration. What else are you going to write? Because looking at the question B, how are you going to answer question B if you decide to go ahead and then explain? You explain by giving other examples. And that is what they're asking you, question B. So make sure that your answers will be precise and concise. Please. They have just 2 days to mark all the theories. Then you start going for the orals. Yeah. So you can't waste their time. The exam, they will just cancel those things and give you low marks. Please, are you okay?
All right, sure.
All right. Okay. So how would you answer the B? So looking at somebody adding extraneous products or substances for supernormal profit, you said is an act of adulteration. Meaning the B, once you know that is an act of adulteration, you should cite 5 other scenarios that also qualifies to be termed as acts of adulteration. So can you cite 5 other ways by which somebody can't commit an act of adulteration? Class captain, can you give me somebody to help?
Okay, so
or you take it.
Okay, so Abigail has raised her hand. So
Okay, Abigail. Let's hear.
So, supplying medicines which are of low quality or substandard, yes, under the name of the main drug instead. So, supplying substandard medications.
That would be a professional misconduct stuff. We are talking about scenarios. You perform an action that can be deemed as you are doing adulteration. You are performing the act of adulteration. As for you knowing that the drug is substandard and you still dispense it, is an act of professional misconduct. At this time, in what cases, what and what scenarios can we say that you have committed adulteration? You've adulterated the medication. That is what we are looking for. One of them is adding extraneous substances to increase the bulk, as they've stated in the case, for supernormal profit. What else? 5 other scenarios.
So, sir, please, adding substances to improve the appearance.
Adding substance to improve the appearance, especially when that thing is not permitted by standards. You can polish it that way.
Yes.
Because every drug has its own formula for preparation. You decide to add other things that is not permitted by standards or the regulations to make it appear better than it should be. Yes, that could be deemed as an act of adulteration. What else? Last Captain, do you remember our introduction to the Public Health Act?
yes, please.
Yes. Those things are stated there.
Yes, please.
About 7 or so or 8 different acts of adulteration. So one of them is if you wholly or partially omit a substituent of the product. As I cited, you have a combination product, let's say para and diclo, then you decide to remove the diclo and still label it as para diclo. You've omitted in part, or there is no para nor diclo, so you've omitted the thing wholly. That's an act of adulteration. Or if you substitute in whole or in part, you have labeled a product celecoxib, relatively expensive than ibuprofen. But we go in there, we check your labeled medicine. The label is celecoxib, but the active ingredient in there is ibuprofen, and you are selling it as what? Celecoxib. You have substituted the thing in whole. So substitution, one, omission is another. Adding the extraneous substance is another one. Then if you conceal a damage to your product, your drug has expired or is getting very close to expiry, so it has a change in odor. It is giving a very bad odor, or it has changed when it comes to color. Then you decide to what? Conceal it. You are hiding it so that it still looks fresh. Or the expiry is due, then you just erase the expiry and rewrite. Or since you have your target, they are illiterate and they don't know anything about expiry, you just erase it. You are concealing a damage to the product. That is another act of adulteration. If you add anything that is not permitted by the standards, yes. Then if you add anything that also makes it appear better, so let's say the active ingredient, you are supposed you have labeled it as 100 milligrams. Since you want people to, as in, know that yours is efficacious, you put in there 150 and you label it 100. So people will compare yours labeled as 100 to another person's labels as 100. Meanwhile, you have 150 in there. That's also an act of adulteration. If you add anything that has been banned, the last time I remember I used chloroform as part of the formula of MMT, where those days it was part. It was serving as a preservative, and it was also contributing a nice taste to the MMT. but that product has been found to be carcinogenic, and therefore it has been removed from the formula. If you still add it, chloroform is not permitted anymore. So it becomes an act of adulteration. And then the last thing is anything at all, aside those things that we've mentioned, that will affect the drug negatively, its nature, its whatever appearance, its efficacy. Anything at all that you do to the drug that will affect it negatively, it is also an act of adulteration. So please, this is a past question, 2016. So please, it means that anything at all is possible. Class captain, so how would you, in terms of the authorities, in what ways can they control and minimize this act of adulteration? Can you suggest some ways and explain how those ways can help reduce or minimize adulteration?
Okay, so as part of the things that we can do, we could conduct or we could make sure that the institutions, so let's say FDA would conduct frequent monitoring of drugs on the markets to be able to curb that issue of adulteration.
Perfect. So that is one. What else? Looking at the marks there, 15 marks. So
you can also set regulations and then enforce those regulations to be able to curb this issue.
Perfect. What else? So monitoring, inspection, setting regulations and enforcing them. What else? Any other ways?
Monitoring the production processes to ensure every process passes the required procedures before passing.
So that'll be part of monitoring and inspection. So you monitor the market, you monitor the manufacturing plants. Okay, so what else? Don't forget drug registration. So drug registration. So almost the things that we said, regulatory factors or parameters that can help promote rational use of medicines. Those that are applicable here could be mentioned. You mentioned monitoring and inspection there. You mentioned drug registration there. Even the premises, the manufacturing premises that they manufacture those drugs in there, they should obey the principles of good manufacturing practices. And it goes with the equipment, the starting materials, the personnel. You start with bad things, you get bad products. And so the authorities should make sure that even the manufacturing plants, they obey or they meet the principles of good manufacturing practice. Then afterwards, the product itself is taken through the registration procedures. Then on the market, they monitor as well. And then they set standards or regulations and enforce them so that if anybody violates it, they can punish that person to serve as a deterrent to others. So at least you can cite this and explain, link them to how they can help us minimize these acts of adulterations. Monitoring and inspection, both the market and the manufacturing, making sure that the premises, the manufacturing premises are also licensed. And before they can be licensed, they have to meet the principles of good manufacturing practices. The 4 pillars, raw materials, equipment, personnel, and the premises itself should meet the principles of good manufacturing practice. The product registration, you know what goes on when it comes to drug registration. We've discussed that. And then setting regulations, high standards, and enforcing them. Are you okay?
Yes, please. Hello, sir.
Yeah, hello.
So please, can you include mass education of the public for them to watch out for?
Of course. Yes. So the authorities can also take it upon themselves and educate the public. As I said, people know, depending on where they are, they know that most of them are illiterate and they don't even know anything about expiry. So they can even erase the expiries and then give you, or they cut them off. Those that are embossed on the blister packs and those things, they just cut them off and give it to them. But once you educate them as an authority and you open their eyes when it comes to some of these things, they also begin to check. So public education is very, very important. Yes, you can add that one. A very strong point. All right. Class captain, are we good to continue?
Yes, please.
All right. So let's look at question 6. The A is trying to ask you to discuss what led to the change in malaria treatment policy. And you have to list 3 options when it comes to the management of malaria in Ghana. So the first aspect is the most important thing. So don't even as in view this as against malaria alone. See it as any policy at all. Policy statement when it comes to disease conditions is about the document directing you as to how the thing is diagnosed, how the thing is managed, the kind of drugs you should use. They are telling you that in Ghana, use this, diagnose it this way. And it's binding. You should go by that because it's also based on evidence, efficacy, safety, good results, cost effectiveness. So go by this policy. In Ghana, if we are saying that use the artemisinin-based therapies for malaria now, uncomplicated, you shouldn't go and be using single agent, amodiaquine only or chloroquine only nowadays. If you do that, it's against the policy. You could be in trouble. Malaria as an example, it started way back. The policy, they developed it. Previously, we were using single agents. Then it goes to a time where they said, oh, we should change to combination therapy, artemisinin. Every now and then, they update the policy. They added some injectables for complicated ones. They started by saying we should use quinine. Nowadays, IV artesunate is first line. Currently, if IV artesunate only fails, they are saying that do it with So why those changes from time to time? Why is it that they are always changing? Any contributing factors? So that is what they are asking you. Discuss what led to the change in malaria policy. So just forget about malaria. Drug policies or treatment policies. What are the possible contributing factors that can lead to a change in policy? And I've told you what goes into policies. The policies is all about the document directing you as to the way the condition is diagnosed, the way the condition is supposed to be managed. Specific choice of medicines recommended by the policies, go by that. How even reviews are done, how go by that is a policy signed by the minister responsible for health. So class captain, what do you think? Possible factors that contribute to change in policy. I'm talking about policies affecting the management of conditions.
Okay, so we could look at issues of treatment failure, maybe due to possible resistance because of so possible resistance that can lead to treatment failure would be one of the things that would lead to a change policy.
Perfect. Because the policy is supposed to enhance efficacy. And if currently what the policy is directing us to do, we are not getting our results, then we must change. So those days when we're using chloroquine and amodiaquine and other even single artemisinin agents, and we are not having success, then it called for a change to what? The double therapy, artemisinin base. What else? So that is one.
Mami Deborah and Abigail, please, you raise your hands.
Doc, Please, can you say that new evidence on a drug that can treat the medication better has been discovered?
Yeah, but you still need to consider cost. So it goes back to the essential medicines list. If it is better and it can treat, but we can't afford, then you don't need to change the policy. Are you okay?
Yes.
Hello?
So
unless you have a better alternative in terms of everything, costs, availability, efficacy, and safety, then you can base on that and change. Are we okay?
Yes, please.
Imagine you have a new anti-malaria that will cost you 1,000 Ghana. Now we have ACTs. Coartem, the maximum, I think the highest price would be, let's say, 110, and it can do the job. And because you have discovered a new drug that can do the job, but you have to pay 1,000 Ghana, it won't call for the change in policy that we should straight to that drug because it's not affordable. Okay, what else? Any other thing?
Drug resistance.
Yeah, that's what class captain said. Resistance and therefore treatment failure.
We could also have issues with how certain populations will tolerate the drugs in terms of adverse drug reactions.
Perfect. So if now we cannot tolerate the adverse drug reactions, so that was a typical case when you consider chloroquine. You take it and you get some reactions, a whole lot of itching. You become very weak. You can't even open your eyes. You are very, very weak, always sleeping. And therefore, you have to change it because people can no more tolerate the drug. Efficacy may be high, on point, but if somebody takes it and cannot tolerate it, based on side effects or adverse drug reaction profile, you have to withdraw the drug. At times, it can even result in the so-called serious adverse drug reaction that may end up taking the patient to the hospital, causing some birth defect, remember thalidomide, it was working as an anti-emetic agent, anti-nausea agent, perfect. But because of the side effects of the adverse effect of birth defect, it was taken out from the market. So side effect or adverse drug reactions that cannot be tolerated is enough to change the policy. So now we have treatment failure due to resistance as an example. Then adverse drug reactions that cannot be tolerated. What else?
Sarah, please, WHO recommendations.
WHO, yes, it's for the whole world though, but you pick that one and as in modify it to suit your own. So if WHO recommends something, it's not little that it may not be practicable in your setting. So they expect you to pick that one as a template and then modify it or assess if it can suit your setting. Sometimes price issues may not even favor you. It depends. At times, even storage conditions may not favor you. So they want you to pick the ideas as just a template, like a dabo, and then you develop your own. So it's not automatic that every WHO recommendation, then you pick it. You may not, but it serves as a guide to develop your own. Are you okay?
Yes. Dr. Babo.
Yeah, hello.
Can we say when new variants of the disease are discovered?
And so that would be efficacy issues, resistance, and those things. So it comes back to class captains one. So treatment failure. So we still have to.
So we can also
Hello, sir.
New ways of diagnosis.
It's still treatment.
we can look at So you mentioned in terms of cost and then the availability of the drug. So if now the drugs are quite expensive and then the availability has reduced, it means that we'd have to consider changing or making amendments to the policy.
Perfect. Perfect, class captain. Thank you very much. So if the drug is not available and it's in the policy, you can't use it. You can't buy. Now it's so expensive that your people cannot buy. Then you have to look for alternatives, and therefore that one too can call for a change in policy. So at least you can have these 3 strong points: cost and availability, resistance, efficacy, intolerable adverse drug reactions. Look, do we have any other thing that we want to add?
Yes, please. Can we talk about when there is abuse of a particular drug due to its additional effect? So, for instance, the Benylin cough that included codeine.
So you declassify the drug. Okay. Why not? If maybe people are abusing it, it is in the policy and therefore it's available and people are abusing it, then the drug can be declassified and therefore the policy will have to be changed. Yes, that's also a possibility, but not that strong point. But you can add it. If people are abusing it and it is declassified, it is taken off the market as Benylin with codeine you cited, then obviously the drug will not be available anymore. And if that is what the policy recommends, it means the policy will have to be changed. All right. Any other contribution? Yeah. Hello.
Please, for the previous guideline, hello, the AL wasn't used in the first trimester. But now it is used. So, like, how will you classify that?
So safety issues.
Safety, okay.
Yes, safety. All right. Any other question? All right. So, class captain, the B, you are to define and discuss briefly the appropriate use of medicines. Instead of rational, we decided to use appropriate use of medicines.
So
it's the same thing.
You go to the B. Hello, sir.
Yeah, hello.
Before you go to the B, it seems like we've been able to generate like maybe 3 main points. I'm wondering if you can explain 3 points to get the 18 marks, or we'll have to get more points. Because so far, all the other examples were being
it doesn't matter. Looking at the points, it's just like when you were to just take adulteration and you were given 5 marks.
Okay.
So, yeah, it depends on whether you've exhausted the points or not. And the points could be just 2.
Okay.
You see that thing? It could be just 2. So, what is left is how you are able to link it to what they've asked you. You've stated the point, but are you able to explain it in a way that will let or convince the examiner to know that, yes, though you've stated the point, but you've linked it to how it could be utilized to minimize the problem. Okay. That is what is left. But I always advise you as a candidate that if you have the chance to choose questions that demand straightforward answers, never choose a question that asks you to discuss. Never.
Yes, please.
Never. Unless you don't have any choice. Maybe these ones are compulsory questions. Then you choose discuss questions. Whilst you have questions that are asking you to state, list, maybe explain, fine. But to discuss, please, always stay away from questions that demand that you discuss, please. Always. Choice of questions is very, very, very key to your success when it comes to exam. There are some people that they prefer choosing difficult questions. because they want to impress the examiner. But all questions carry equal marks. If you go and choose difficult questions and you get low marks, no. Choose the easy questions, get your 100%. It is the mark that will impress the examiner, not your choice of questions. You see, at times, the examiners, when they see that you've tackled a certain question, they even shout when they are marking, hey, I'll question with. Because it's intentional, they try to put in certain questions, but they don't expect any student or any smart student to choose that question. If you have what is 1 + 1 as question 1, question 2 is explain the principle behind polarimetry. The 2, 10 marks, you have to answer one of them. Then you dodge what is 1 + 1. Then you go and choose explain the principle behind polarimetry. You are not a smart student. You are not a smart student. So examiners at times don't even expect candidates to tackle certain questions. So please be smart when it comes to your choice of questions. Always go for the easy ones. It is true that during your rotation, your training, you presented on heart failure or kidney. It doesn't mean that by all means, when a question on heart failure drops, no matter how difficult it is, since you believe that you are the expert in heart failure, you should answer. No. You have to take your time. The moment they say start work, don't put any pressure on yourself. You need to spend about 5 minutes or so to assess all the questions. I mean the theory part. As for the MCQs, you don't have any choice than to answer all. But the theories, you're always going to choose. So make sure that you assess all the questions and choose the easier ones, please. Choose the easy ones.
Easier ones first.
Yes, as for objects, secure the easier ones so that when they say stop work, you will not, because there are some objects that you can spend 100 hours on, you will still get the answers wrong. You don't need to waste your time on those ones. You have one objective question that covers almost half a page. All the options, lengthy statement, and you are wasting your time on that. Whilst you have the ones that you can even read up to half of the question and straight away you won't even continue, but you know the answer. Why don't you go and secure all those ones before you come back and then spend time on be smart? GPQE passing is about smartness. It's not about, yes, how good you are, fine. But if you are not smart, you may be a first-class student and still fail. We have so many first-class students who have failed GPQE because they were not smart or did not know what to do. So please be smart when you are choosing. Class captain, are you okay?
Hello, Dr. Bobo.
Yeah, hello.
Yeah, please, pertaining to the question the lady asked, I think with regards to the 18 marks, the question is a 2-in-1 question. So it talks about the treatment policy and 3 treatment options.
Yes, that one you know. That's why we did not spend time on. We've done malaria policy. Is that not so?
Yes. So she's saying just stating the 3 points. You'd actually have another question.
Yes, of course.
To sum up to the 18.
Yeah, of course. All right. So let's do the B. You are to discuss the appropriate use of medicines. Don't let the word appropriate confuse you. It's the same rational use of medicines. So don't say that rational use of medicines are mad. Meanwhile, you have appropriate use of medicine. And so you don't know this. You sit there and be crying. It's just choice of words. So class captain, how do you approach this? Define and discuss. As I said, it will be better for you to dodge discuss questions if you have straightforward. Please mute your mic.
Okay. So for the appropriate use of medicine.
So now just describe how you would approach. If you want to answer it by just as in saying all the things, we are not going to live today. So how would you approach this question? Define and discuss briefly appropriate use of medicine.
So for this, we are looking at the appropriate use of medicine. So in defining the appropriate use of medicine, you want to look at the effective use of the medications to achieve the best possible health outcomes. And then you state the 4 cardinal points that are used in the definition of rational use of medicine. So you can talk about, so you are looking at giving the patient medications that are.
So don't state the specific, just describe how you answer. Yes, let's describe.
So after stating that rational use of medicine looks at giving effective medications or effective use of medications to achieve the best possible health outcomes, then I would list the cardinal
examples will come in. The cardinal points will come. Examples you cite.
Yes.
What else?
Yes.
And then the assessment will follow. Assessment of the problem of rational use of medicines, where you assess the type, the magnitude, and the reason behind irrational use of medicines. Never forget to make that statement after defining the appropriate use of medicines, that anything that goes against the rational use becomes, then you cite strategies that can be used to curb irrational use of medicines. Then you conclude. So that is how it's supposed to be.
Hello, sir.
Yeah, hello.
I missed it. You said anything that goes against something. I didn't hear that part.
Anything that goes against the principles of rational use of medicines will make it what? Irrational use. That statement is very important. Yes.
Okay.
So you define it, you cite examples, you assess the issue of irrational use. That is the reason behind the magnitude and then the type of irrational use. Then you cite the interventions, try to explain a few of them, how they can be used to curb irrational use of medicines. Then a very short conclusion. That's all. Okay, so class captain, that will be it for today. I'm trying to discuss pharmacy, whatever stuff with Dr. Ishak. And then we will know who will teach it. But technically, I'm done with you guys. So the way forward is you still have 3 weeks or so. And even the week for the exam. So we are not done until you are done with your orals. The last person is done with his or her oral. So what I would advise is that I know that some people, they are shy asking questions here, like in the open platform like this. If you have any question, if you have anything that you want us to discuss, please get my contact and you can call or WhatsApp me at any time. It doesn't matter whether it's in the morning, afternoon, or at night. I'm always available. You just contact me. Whatever you want us to discuss, whether it's a question or an explanation or whatever, I'm always available until you are done. Then you can call it. So please feel free at any time. If I'm busy, I'll let you know and I'll call you right after whatever I'm doing. So if you call and I'm unable to answer your call, you just send me a message. Just send me a message that yes, you are this, and you want us to discuss something. I'll call you. Or I'll text you back. Then through whatever platform, this is the time. So that chance has been activated from today. So henceforth, you are free to call or contact me by any means, any medium or any media. Are you okay, class captain?
Yes, please, sir.
All right. Okay. So any announcement or anything? If not,
no, please.
All right, then. Thank you very much. Do not panic, please. Do not panic. You have more than enough information for your GPQE. You have more than enough. You panic, you freeze. Anxiety is normal. Even if you were going to do 1+1 paper, you would be anxious. That one I understand. But the anxiety is to push you to learn more so that you'll be able to face the paper. But do not panic. You have more than enough information. What we have discussed since February. That is one aspect. And the things that you've been taught from first year to 6th year, you've done difficult things than what you are going to face in the exam. That is not to say that the exam is easy. It's not easy, but you have more than enough to pass this exam. You can get 40% wrong and still become a pharmacist. You are not expected to score 100% before you become a pharmacist. And I believe strongly that you have what it takes to get at least 60% to become a pharmacist. So do not panic. Just keep on reading. Just keep on the revision and your preparations. But in case you don't understand anything, you can contact any of us or contact any of your colleagues that you believe can help you. All right. So have a good day. Vice Captain, if anything, please let me know.
Yes, please.
All right.
Thank you, sir.